Welcome to the deep dive. Today we're tackling a really significant health issue, a vascular necrosis of the femoral head.
That's right. You might also hear it called osteonecrosis of the femoral head, or sometimes just FHN, femoral head necrosis.
Right, FHN. Essentially, we're going to explore this condition that affects the hip joint and also look at a fascinating potential way to address it.
Exactly. We've been really immersed in some detailed sources, specifically chapters from the textbook Hyperbaric Medicine Practice.
Okay.
And our main focus has been chapter 34, which looks very closely at using hyperbaric oxygen treatment, HBO2, for this condition, AVNFH.
Got it. So our mission today is really to understand AVNFH. What's actually happening in the hip? Why does it happen? How is it usually managed? And then take a really good look at the science behind hyperbaric oxygen therapy as a possible solution.
Right.
And for you listening, think of this as your shortcut, a way to get a solid grasp on a complex medical topic and a potential non-surgical treatment, saving you, well, hours of searching. So let's start at the very beginning. What exactly is a vascular necrosis of the femoral head? Can you break that down?
Sure. In straightforward terms, it's a condition where the blood supply to the femoral head gets disrupted.
The femoral head being the ball part of the hip joint.
Exactly. The ball at the top of your thigh bone, the femur, that fits into your hip socket.
Okay.
And this lack of blood flow, this ischemia, causes the bone cells to die.
Die off completely.
Yes. And over time, this cell death can lead to tiny breaks, microfractures in the bone, and eventually, well, the whole thing can collapse.
Collapse of the joint, wow.
Yeah, the structural integrity fails. And it's important to note, this isn't just something affecting older people.
Brilliant, you mentioned that.
It can impact people of really any age, including young, active individuals.
That's kind of surprising. It sounds really serious.
Yeah.
And you said it's maybe more common than we might think.
It is, yeah. Particularly in the Western world, the average age when it starts is around 39.
39, that's young.
It is, and it's actually a major reason why people end up needing hip replacements. It accounts for at least 10% of all total hip replacements.
10%. Okay, that really underscores the significance, doesn't it?
Absolutely. It's a big deal.
And the natural course of this condition, if, nothing is done, it sounds pretty grim, like a steady decline in hip function.
Unfortunately, yes. Typically, it progresses towards functional loss of the hip. Spontaneous regression, where it gets better on its own, is very rare.
So intervention is usually needed.
Pretty much, yes. Which brings us to the million-dollar question. Why does this happen? The pathophysiology?
Right. What's actually going wrong?
Well, the precise mechanisms, they're still being figured out. It's actually quite complex.
Why is it so hard to pin down?
Part of the challenge is that we don't have a perfect animal model. A bipedal mammal model that truly mimics how it develops in humans.
Oh, okay.
And also, doing long-term studies in people, tracking it from the very beginning, that's really difficult logistically and ethically.
Makes sense. Okay, so let's try to piece together what we do know about what's happening at the cellular level. What are the kind of key events?
Okay. So the process seems to start with cell death. First, it's the hematopoietic cells, the blood-producing ones, and the adipocytes, the fat cells, in the bone marrow. They die off first.
And then the bone cells.
Then the osteocytes, the actual bone cells, follow. After that, the body tries to repair the damage. It starts breaking down the dead bone and forming new bone.
Like a healing response.
Sort of, yes.
Oh.
But the problem is, this repair process is often incomplete. It doesn't quite manage to rebuild effectively.
Okay. Ineffective repair.
Yeah. And a central issue seems to be the compromised blood flow in the tiny vessels, the microcirculation, just beneath the cartilage surface in the hip.
So right under the joint surface.
Exactly. And this leads to a significant drop in the oxygen levels, the PO2, within the bone itself.
So it's really an oxygen starvation issue at its core.
That seems to be a key element, yes, like a domino effect starting with the lack of blood and oxygen.
Okay. And the source material mentioned, I think, 3 main ways this blood flow gets cut off.
Yes, that's right. 3 main pathogenic mechanisms seem to be involved.
What are they?
Okay, the first is direct vascular interruption. Think trauma, like intracapsular femoral neck fractures or dislocations around the hip joint. They can physically tear or damage the blood vessels.
Right, like a physical break in the supply line.
Exactly. The second is intravascular occlusion. This is where the blood vessels themselves get blocked from the inside.
Blocked by what?
Things like thrombi, which are blood clots, or maybe fat emboli, little globules of fat.
Okay. Clots or fat blocking the pipes.
Precisely. And the third mechanism is intraosseous extravascular compression.
Intraosseous. Extravascular. Okay, say it again.
Intraosseous extravascular compression. Think of it like a garden hose getting squeezed from the outside.
Ah, okay. Pressure from outside the vessel.
Yes. If the pressure inside the bone itself gets too high, it can compress the blood vessels running through it.
What would cause that high pressure inside the bone?
It can be caused by things like hypertrophy or enlargement of the fat cells within the bone marrow, or in certain conditions like Gaucher disease, you get these specific cells building up. Elevated intraosseous pressure itself, just generally higher pressure in the bone, is also implicated.
That's a really helpful analogy with the hose. So different triggers can start this whole cascade. What are some of the specific causes and risk factors that have been identified?
Well, the list is actually quite broad. Trauma, as we mentioned, especially those hip fractures, is a big one.
Okay.
Then you have conditions that directly affect blood vessels or blood itself, things like sickle cell disease,
Right.
certain coagulation disorders like hypofibrinolysis or thrombophilia, where the blood clots too easily or doesn't break down clots properly, lipid thrombi, those fatty blockages too,
Okay, so blood-related issues. What else?
things that increase that extravascular pressure inside the bone. Corticosteroid use is a major one.
Steroids, like prednisone.
Yes, exactly. Long-term or high-dose use is a well-known risk factor. Alcohol intake, particularly heavy consumption, is another.
Alcohol, too. Interesting.
Yeah, and that genetic disorder, Gaucher disease, we mentioned. But there are other associations, too.
Like what?
Things like hyperlipidemia, high cholesterol or triglycerides. Hypouricemia, which is high uric acid, like in gout. Pancreatitis.
Pancreatitis. How is that linked?
The exact link isn't always perfectly clear, but it's an observed association. Also, leukemia, lymphoma, radiation therapy, bone marrow transplantation,
Wow, quite a list.
metastatic cancers, even pregnancy sometimes. And interestingly, disparate conditions and diverse, the bends, decompression sickness.
Decompression sickness. Okay, that's another vascular connection, right? Gas bubbles.
Precisely. It's a really wide range of potential factors.
It really makes you realize how complex this condition can be. You could have multiple things contributing, potentially.
Absolutely. It's often multifactorial.
So, given all that, it sounds like catching this early is, well, really important for treatment to have the best shot.
Definitely. Early diagnosis is key for better outcomes.
How does AVNFH typically present itself? What are the symptoms and how is it diagnosed?
Well, initially, it can be quite subtle, often asymptomatic in the very early stages.
So no pain at first.
Not necessarily, no. But as it progresses, people might start feeling pain. Sometimes it's felt in the knee, surprisingly.
Knee pain from a hip problem.
Yeah, it's called referred pain. Or they might feel pain in the buttock area. Notice limited range of motion in their hip.
Like stiffness.
Stiffness, yeah, or difficulty moving it fully. And sometimes a characteristic sharp stabbing pain, especially when they try to rotate their hip inwards, like turning the foot inwards.
Okay, so knee pain, buttock pain, limited motion, that's stabbing pain.
Those are key things to look out for. And taking a detailed medical history is crucial to identify those risk factors we just discussed.
Right, asking about steroid use, alcohol, other conditions.
Exactly. And interestingly, in the very early stages, standard x-rays might actually look completely normal.
So you could have it, but the x-ray doesn't show anything yet.
Correct. That's why it can be missed early on. It's also really important to remember that AVNFH often affects both hips. It has a high rate of bilaterality.
Oh, right. So it's found in one hip, the other should be checked too.
Definitely.
So if someone's having unexplained hip or even knee pain, and maybe the x-rays are clear, this AVNFH might be something a doctor needs to consider further.
Absolutely. It should be on the differential diagnosis list.
What other tools do doctors use then to get a clearer picture, especially if x-rays are normal early on?
Beyond the history and physical exam, there are several diagnostic methods. You can do histological studies, but that's invasive, taking a tissue sample.
Right.
There's scintigraphy or bone scans, functional evaluations of the bone, and then more imaging. Plain x-rays are still used. CT scans can give more detail.
But the best one is?
Currently, magnetic resonance imaging, MRI, is considered the gold standard. It's the most accurate and sensitive way to diagnose AVNFH, especially in those early stages before x-ray changes appear.
MRI picks it up earliest. Got it. And I noticed in the material there are different classification systems used. Names like FECAT, Steinberg, ARCO. What's the point of those?
Yeah, those classification systems or staging systems help doctors categorize the severity of the AVNFH based on the imaging findings, primarily.
So like stage 1, stage 2, et cetera.
Exactly. This staging is really important because it helps guide treatment decisions and gives an idea about the prognosis, the likely progression of the condition.
Can you briefly explain the differences?
Sure. The FECAT system was one of the earlier ones, mostly based on X-ray findings. Steinberg's system kind of expanded on FECAT and tried to quantify how much the femoral head was involved, like the percentage of the head affected.
Okay, adding quantity.
Right. And then the RRCO system, that stands for Association Research Circulation Osseous, aimed to be even more comprehensive. It incorporates findings from MRI, bone scans, histology, not just X-rays.
So RC is maybe the most detailed.
It aims to be. But really, the current trend in diagnosis heavily emphasizes MRI for both detection and staging.
Okay, so MRI is key, right? We now have a much better understanding of what AVNFH is, the risks, the symptoms, and how doctors figure out if someone has it. Let's shift gears now to how it's typically managed. Let's park the hyperbaric oxygen therapy for a moment.
Right.
What are the standard treatment approaches?
Okay, so standard management, excluding HBO2 for now, generally falls into a couple of main categories. Pharmacologic agents, basically medications, and biophysical treatments.
Mids and physical therapies?
Sort of, yeah. Surgical interventions are obviously options too, things like core decompression to try and save the joint or total hip replacement. But our source material today focuses more on the non-surgical side.
Got it. So let's start with the medications. What kinds of drugs are typically used?
Several types are tried, usually aiming to slow down the progression. One group is lipid-lowering agents like statins.
Statins for cholesterol. How do they help here?
The idea is they can reduce adipogenesis, the production of those fat cells in the bone marrow. This might reduce that intraosseous pressure we talked about, and they seem to have a protective effect, especially for people taking steroids.
Ah, interesting connection. What else?
Anticoagulants, like enoxaparin, a low molecular weight heparin, they help prevent platelet aggregation, basically stop blood cells from sticking together, potentially improving blood flow.
Makes sense if clots are part of the problem.
Exactly. They seem most beneficial in patients who actually have underlying blood clotting disorders.
Okay. Any others?
There are vasoactive substances like prostacyclin analogs. These help dilate or widen blood vessels, again, trying to improve blood flow.
Improve the supply line.
Right. Though the long-term benefits of these are still being evaluated more thoroughly.
Okay. And one more group mentioned was bisphosphonates, like for osteoporosis.
Yes, exactly. Drugs like alendronate. They work by decreasing the activity of osteoclasts. Those are the cells that break down bone.
So slowing down bone loss.
Right. The hope is that this can reduce the risk of the femoral head collapsing, especially in the early stages. They might also help reduce pain.
Does it prevent needing a hip replacement?
Well, that's still debated. Their utility in actually preventing the need for total hip replacement, or THR, in the long run. The evidence isn't definitive yet.
Mm-hmm. So these medications are trying to tackle different angles, pressure, blood flow, bone breakdown. What about the biophysical treatments you mentioned? What are those?
These are non-drug, non-surgical physical methods. One is extracorporeal shockwave therapy, or ESWT.
Shockwave therapy, like they use for kidney stones.
Similar technology, yes, but applied differently here. It uses focused sound waves directed at the hip. The theory is it helps restore oxygenation, reduce edema or swelling, and induce angiogenesis, the growth of new blood vessels.
Trying to kickstart healing and new blood supply.
Exactly. It's being looked at as a potential substitute for more invasive treatments.
Interesting. What else?
Another one is pulse electromagnetic field therapy, PEMF. This uses magnetic fields. It's thought to stimulate osteogenesis, bone formation, and maybe angiogenesis too.
Magnetic fields for bone growth.
That's the idea. But again, its precise role, especially in early stages, still needs more solid confirmation from good research.
Okay, so it sounds like these conservative treatments, the meds, the ESWT, the PEMF, they can be helpful, particularly if AVNFH is caught early.
They can potentially help manage symptoms and maybe slow the disease process, yes.
But the source material also seemed to suggest we need more long-term research, more randomized controlled trials to really know how effective they truly are.
That's a really crucial point. While these options exist and are used, there's definitely a need for more high-quality long-term studies to nail down their efficacy.
Right, and this is where the interest in hyperbaric oxygen therapy, HBO2, really comes into the picture, isn't it?
Exactly. It represents a different kind of approach.
Okay, this is where it gets really interesting for our deep dive. The core idea The rationale behind using HBO2 is that it might actually be able to delay or even prevent the need for hip replacement surgery without surgery itself. How? What's the mechanism supposed to be?
Well, the fundamental belief is that HBO2 directly tackles that core problem of low oxygen, the hypoxia, in the affected bone.
By getting more oxygen in?
Precisely. By having the patient breathe 100% oxygen inside a pressurized chamber, you dramatically increase the amount of oxygen dissolved in their blood plasma.
Okay.
And consequently, much more oxygen gets delivered to the tissues, including that struggling bone tissue in the femoral head.
So flooding the area with oxygen, what does that oxygen do once it gets there?
Several things, potentially. First, it helps reduce the effects of the ischemia, the lack of blood flow. It can also reduce edema or swelling. Interestingly, it does this partly through vasoconstriction in healthy tissues.
Wait, vasoconstriction? Narrowing blood vessels. Wouldn't that be bad?
It sounds counterintuitive, right? But by slightly constricting vessels in well-oxygenated areas, it might help redirect blood flow toward the ischemic, oxygen-starved areas. And overall, it reduces swelling, which can lower that damaging intraosseous pressure.
Okay. Reduces pressure, helps redirect flow. What else?
It's also thought to directly stimulate angiogenesis, the growth of new blood vessels into the damaged area, creating new supply lines.
Building new infrastructure.
Exactly. And it seems to influence the activity of the bone remodeling cells. We talked about the osteoblasts that build bone and the osteoclasts that break it down.
Okay, so it's interacting directly with the bone healing process. How does it affect that balance between building and breaking down bone?
Research suggests HBO2 helps shift that balance towards bone formation. It appears to accelerate the differentiation and activity of the osteoblasts.
Speeding up the builders.
Yes, and at the same time, it seems to suppress the genesis and activation of the osteoclasts, the bone removers.
Slowing down the demolition crew.
Kind of, yeah. One possible way it might do this is by increasing the levels of a protective protein in the blood called osteoprotegerin, or OPG.
OPG, yeah.
And this is really significant because in AVNFH, that balance often tips too far towards bone breakdown, resorption, which leads to the weakening and collapse. So shifting it back is key.
That sounds like a really powerful set of potential effects, reducing swelling, boosting oxygen, growing new vessels, and rebalancing bone turnover.
It's quite multifaceted, yeah.
Okay. So the source material you look at, Chapter 34, included a review of studies on HBO2 for AVNFH, specifically between 2003 and 2016. What were some of the key takeaways from that literature review?
Right. The chapter summarized several studies in a table. They had different designs, some retrospective, some prospective, a couple of randomized controlled trials, or RCTs.
What did they generally find?
Well, it varied a bit, as research often does, but some studies showed pretty encouraging results. For instance, a retrospective study by Rees and colleagues in 2003 looked at patients with early-stage AVNFH, Steinberg stage I.
Okay, very early.
Yes. They found that 81% of the patients treated with HBO2, about 100 sessions, showed complete recovery on their MRI scans after 2 years. That compared to only 17% in the untreated group.
81 versus 17%. That's a huge difference.
It was, yeah. The study was rated as moderate evidence favoring HBO2.
Okay. What about randomized trials? Those are usually considered stronger evidence, right?
They are. There was an RCT by Camporisi and colleagues published in 2010. They looked at patients with slightly later stage, FICAT stage 2.
Okay.
They compared HBO2 30 sessions at 2.5 atmospheres against breathing hyperbaric air at the same pressure, so it was a sham control, though only blinded for part of the time.
What did they find?
The HBO2 group showed significant pain reduction and, importantly, improved hip range of motion extension, adduction, abduction compared to the control group.
Real functional improvement.
Yes. And what was really interesting was that MRI improvements in the HBO2 group continued for up to 7 years after the treatment. This study was rated as high evidence favoring HBO2.
7 years of continued improvement. That's impressive.
It certainly suggests a lasting effect in that group.
But you said the picture wasn't entirely clear-cut. Were there studies that didn't show such strong benefits?
That's right. For example, another RCT by Su and colleagues in 2009 looked at RCO stages 1 to 3. They compared adding HBO2, 20 sessions, to a baseline treatment of the bisphosphonate alendronate plus shockwave therapy, ESWT, versus just giving the alendronate and ESWT alone.
Okay, HBO2 is an add-on therapy.
Exactly. And in that study, they didn't find a significant difference in the outcomes between the two groups after 2 or more years. So that study was considered neutral towards HBO2, although the evidence level was rated low.
So one RCT positive, one neutral. What about other types of studies?
There were several case series, which are basically reports on groups of patients treated similarly. For example, Wong et al. In 2008 reported on patients treated with a combo of HBO2, alendronate, and ESWT. They found no lesion progression and improved pain and function scores at 4 years.
But hard to tell which treatment did what, right?
Exactly. It's hard to isolate the HBO2 effect. It was rated as low evidence, lightly phaging HBO2. Similarly, Zhao et al. In 2010 looked at patients who developed AVNFH after SARS. Remember that?
Oh, yes. Steroids used for SARS were linked to AVNFH, weren't they?
They were, yes. This study showed decreased lesion volume on MRI after 5 years in patients treated with HBO2 plus other meds. Again, low evidence, lightly favoring HBO2.
Okay. So a mix of findings, but definitely some strong signals, especially for that Camporese RCT and the Reese retrospective study, particularly for earlier stages.
Yes, the evidence seems generally supportive, particularly for FETCAT IN2 or early Steinberg stages, but it's not uniformly conclusive across every single study or methodology.
Right. So the human studies are, well, promising but mixed. What about research using animal models? Did those studies shed any more light on how HBO2 might be working?
Yeah, the animal studies, mostly done in rats, provide some valuable mechanistic insights. They generally suggest that HBO2 can enhance the activity of various cells involved in the repair process.
Which cells?
Fibroblasts, which make connective tissue, angioblasts, involved in forming new blood vessels, the osteoblasts, the bone builders, and even osteoclasts, the remodelers. The idea is it accelerates the overall recovery process.
So boosting the cellular repair team.
Pretty much. For instance, one study by Carioca in rats showed HBO2 actually prevented osteonecrosis from developing and also prevented disturbances in ossification or bone formation.
Prevented it. That's strong.
In that specific rat model, yes. Another study by Levin, also in rats, found that the group treated with HBO2 showed significantly more new bone formation and more advanced remodeling compared to the control group.
Supporting that idea of rebalancing bone turnover.
Exactly. And one more interesting finding came from combining HBO2 with non-weight bearing in rats.
Yeah.
That combination seemed to preserve the femoral heads better and led to better regeneration of the hematopoietic tissue, the blood-forming marrow.
Suggesting maybe combining HBO2 with offloading the hip could be beneficial.
It points in that direction, potentially predicting better functional outcomes.
Okay, so those animal findings do seem to lend biological plausibility to the positive results seen in some of the human studies.
They definitely help strengthen the rationale, yes.
So putting it all together, the human studies, the animal models, the mechanisms who might be the most suitable candidates for considering HBO2 as a treatment option for AVNFH, where does it fit in?
Well, the field seems to be shifting. HBO2 is moving from being seen as maybe just an anecdotal or alternative option towards being an evidence-supported treatment choice, especially under specific circumstances.
Like for certain stages?
Primarily, yes. Some studies, like that Camporese one, reported significant success rates even at long follow-ups, like 7 years. And there was other work mentioned by Vazani and colleagues who followed patients treated between 2004 and 2013.
What did they find?
They showed a high success rate, meaning patients avoided surgery in those with FECAT stage I and II AVNFH treated with HBO2. And interestingly, even about half of their patients with FECAT stage 3 managed to avoid surgery at the 4-year follow-up mark with HBO2 treatment.
Half of stage 3. That's pretty significant for a later stage.
It is, yeah. So the therapy is generally considered safe, and it can be combined with other non-surgical treatments like physical therapy or potentially those medications we discussed earlier.
And the key benefits are thought to be?
The key physiological effects seem to be reducing that edema and intraosseous pressure, improving oxygenation directly, restoring venous drainage perhaps, and improving the microcirculation through angiogenesis.
So, based on the evidence reviewed in the chapter, the conclusion seems to be?
The conclusion is that there's moderate to strong evidence suggesting HBO2 is a feasible and efficient treatment option for FICAT stage I and II, and generally early stages of hip necrosis. It might be particularly useful when combined with procedures like core decompression, although that's moving into surgical territory.
Okay, so a potentially valuable tool, especially for early AVNFH. The source material even mentioned a specific protocol that's accepted in Italy.
Yes, it outlined a common protocol use there as an accepted indication.
What does that typically involve? How often? How long?
It's typically 1 treatment per day, 5 to 6 days a week. Each session lasts for at least 60 minutes, where the patient is breathing 100% oxygen, FiO2 equals 1,
And the pressure.
usually between 2.2 and 2.5 atmospheres absolute, or ATA.
Okay. And for how many treatments total?
The recommendation is typically for 60 to 90 treatments in total. This number aligns pretty well with the number of sessions used in many of the studies that showed positive results, which were often around 70 or more treatments.
60 to 90 sessions. That's quite a commitment doing that 5-6 days a week.
It is a significant time commitment, absolutely, often done in cycles.
Right. And what about the cost? Is this financially realistic compared to, say, going straight for a hip replacement?
The chapter provided an estimate for the cost in Italy. The average cost per patient for a full course of therapy was estimated to be around 8,000 to 9,000 euros.
8 to 9,000 euros. How does that compare?
Well, when you consider the cost of a total hip replacement surgery, including the surgery itself, hospital stay, rehab, potential complications, and the fact that replacements don't last forever and might need revisions.
Right. Revisions can be complex and costly.
Exactly. So in that context, the cost for HbO2 therapy is often considered quite reasonable if it can successfully help the patient avoid or significantly delay the need for that joint replacement surgery.
Yeah, that definitely puts the cost into perspective. Saving your own hip, even if delayed, has huge value.
Immense value, biologically and functional.
Okay. So based on all this information we've dug into, what are the main conclusions and recommendations from the source material regarding using HbO2 for AVNFH? What's the bottom line?
The authors of the chapter conclude by recommending daily HbO2 treatments for at least 60 minutes per session at a pressure of 2.4 to 2.5 ATA.
Yeah.
Doing this 5-6 days a week, often in cycles of maybe 4 to 5 weeks per cycle, and this is particularly recommended for the initial stages of femoral head necrosis.
Stage I and II primarily.
Primarily, yes, where the potential for hip preservation is greatest. They also really stress the importance of combining HbO2 with other adjuvant measures.
Like what?
Things like minimizing weight bearing on the affected hip, maybe using crutches, working towards a healthy body mass index or BMI if overweight, engaging in appropriate physical therapy, and, importantly, quitting smoking if the patient smokes.
Smoking affects blood flow, right? So that makes sense.
Absolutely, smoking is detrimental to microcirculation. And finally, they recommend regular monitoring, using MRI scans and having orthopedic evaluations, typically about 3 to 4 weeks after completing a cycle of HbO2 therapy, to track the progress and see how the bone is responding.
Okay, let's try and summarize the key takeaways then.
Yeah.
So AVNFH, this avascular necrosis of the femoral head, it's a pretty serious condition where the top of the thigh bone loses its blood supply.
Right, leading to bone death and potential collapse of the hip joint.
And while there are standard treatments like medications and physical therapies and eventually surgery, our deep dive into this source material, particularly Chapter 34 of Hyperbaric Medicine Practice, suggests that hyperbaric oxygen therapy shows, well, significant promise.
Yes, particularly when it's used in the early stages of the condition.
And the way it seems to work is by dramatically increasing oxygen levels in that damaged bone tissue.
Exactly, which appears to help reduce swelling, promote the growth of new blood vessels, and rebalance bone remodeling in favor of repair.
Potentially helping people delay or maybe even avoid the need for a surgical hip replacement.
That's the goal, and the evidence suggests it's achievable for a good number of patients, especially those diagnosed early.
What's really intriguing here, I think, is this potential for a non-surgical approach like HbO2 to fundamentally change the course of what is essentially a degenerative bone condition.
Absolutely. The growing body of evidence from both clinical trials, case series, and those animal studies makes a pretty compelling case for considering it as a serious option, particularly in those earlier Ficat and Steinberg stages.
So this naturally leads to a final provocative thought for you, our listener, to mull over. Given the clearly multifactorial nature of AVNFH, all those different risk factors, and our still evolving understanding of exactly how HbO2 works at a biological level, what other combined or perhaps highly personalized treatment approaches might hold even greater promise in the future? Could we tailor treatments even better?
That's a great question. And related to that, what further unanswered questions about the long-term effectiveness of HbO2, maybe beyond that 7-year mark we saw, and finding the truly optimal treatment protocols, pressure, duration, number of sessions, what really deserves more focused investigation?
Definitely gives you something to think about. Thanks for joining us for this deep dive.